Okay, colleagues, thanks very much for all coming to share this. If you are watching this at home, welcome to you also. Important day this. There's a lot of work been going on in CQC about how we engage with people that are using services so that you can help us be as good as we can be in terms of the responsibilities that we've got. And I was given some notes for this, and it made me think, about 30 years ago, there was a group of people living in a Leonard Cheshire home who said, actually, this service isn't very good. If you give us the money, we'll run this service better ourselves because we're better at making decisions about what we need to lead our lives than those of you that are in positions of influence and power at making decisions about us. And I think from that conversation 30-odd years ago now, a whole conversation began about how important it was to engage with people using services, to listen to people using services, and to act on what people said about how their needs can best be met. And I think 30 years later, I think we've come a long way. Some would argue we've not come far enough. But one of the things that we do know is that if we treat people as having strengths that we can build on rather than having deficits which need to be filled, we'll move a lot further in supporting people to live the lives that they want to lead. So what we're doing today is actually really building on that work, and we've been challenged, I think, by recent failures of care, whether that's the report that Robert Francis has published in relation to Mid-Staffordshire, or the work that has been done on failures in relation to those services for people with learning disabilities. What's been emphasised over the past 2 to 3 years is this important value of professionals listening to people that use services, and not just listening to what people say, but acting on what they say. It's important whether it's in healthcare, social care, mental health services, primary care services. So, the statement that we're launching today really demonstrates how much of a priority listening to people and acting on what they say is for CQC. What we're going to do today is listen first to Nick Gradwell, who's an expert by experience, who's worked with us and worked with many organisations over a number of years, and as a member of our Equality Voices group. Nick has done a number of inspections with us, and he will introduce his view of the importance of engaging people that use services. And then my 3 colleagues, who I'll introduce in turn, will each say how they're taking forward the engagement of people that use services in the way that we're organising our work. So that's what we're going to do today. Thanks all for coming. If you're listening at home, thanks for turning us on. And Nick, if I can invite you to come and share your thoughts with us and get us off to a good start. Thanks.
Okay, I'm pretty confident that people can hear me because I can hear my own voice echoing, so I'll try and get a move on. Thanks to my wife Kath, who does my support, is just helping me to and fro. And if I seem to be singing and dancing around a bit, it's partly because I've got to speak very fast, and also with not too much levity in all this sort of very important event. It's because, as an expert patient as well as an expert by experience, I've realised how to use my water tablets really well recently, so I will really get a move on, I promise. In fact, they work that well. That's an anecdote for another time. But at the moment, this is, of course, a very serious issue. What is involvement, and what's this statement, this document that I'm waving here all about? I sort of, as somebody who's blind for 20-odd years and looking as a joint carer of my wife and from my wife at several years, looking after my mother in her last years of life, the profoundness of health and well-being really drops in on your lap when you lose a bit of it. And we're all going to lose a bit of it, and hopefully for anybody watching or listening, it won't happen to you today, but it might be something that affects you or your partner, and it will come along. and the difference it makes is immense. So health and social care services are immensely important. There's nothing else. If you don't have that, then everything else, all your aspirations and dreams count for naught. But obviously, if they're good services, then how you can get involved in those services becomes really important. And I was lucky enough with my career to be able to get involved because of my, I suppose, my professional training up to the point when I lost my sight. And I've learned over the last 25 years, whilst I've been blind, that increasingly those services are trying to involve people, but it's work in progress. And okay, if that means, you know, this concept of involvement is so important, well, surely it's happening anyway. Well, that's what demonstrates why involvement is really important, because it's obvious from reading the Francis reports and all the others, and I don't want to demonise those organisations. Many I know and I've seen were lucky enough not to be the people inspected on the days that those things happened. And what was clear, and it's clear in all the bad service, is that some senior people don't get involved enough. And also some frontline staff don't get involved enough, or they get involved in the wrong way. And of course we've seen in the reports the emotive stuff, which is dreadful and really happened. People walking by when people are in pain and discomfort. How can that happen? How can these people do this? Because getting involved isn't easy, and it's tempting not to. It doesn't do a lot of people's careers a great deal of good when they keep fostering up the bad news that it ain't so good out there on the wards or in the care rooms or out where the staff are visiting. You don't bring good news to the table all the time when you get involved. You don't get instant solutions. You might simply get more problems. You'll get a better defined problem, but you certainly won't suddenly have enough time, money or staff to be able to wish it all away. Getting involved is profound stuff. And it draws us into issues, often frankly, which are going to get us involved. And it's to the credit of the Care Quality Commission that, fresh on the heels of the Francis report, they got involved in yet more problem and strife and trouble. They took the lid off what was happening in some of their own work around inspections. And they weren't afraid of the fact that Mr. John Humphreys was there to sort of remind some senior people just how dreadful he thought that was. Because getting involved, it can be very, very difficult. But it's to the credit of the Care Quality Commission and the people in Parliament that they have a duty to get us involved. And this document is not a statement of involvement to me, it's a people plan. It's how the Care Quality Commission gets involved with people. Now, calling it a people plan certainly doesn't sort of ring a bell with most people in high levels at Parliament and the drafts people. But what is clear is that for people either watching or here today, being involved is exactly what a people plan tends to do in an organisation like the Care Quality Commission. And it's got me involved over the last 18 months in a closer way than in the past as one of these experts by experience. I go and I talk with people. I have talked with about 480 people in really quite long conversations where they tell me what they feel, what to them is good or outstanding care. What, if you like, is safe, effective, what it means. I have a really clear idea from listening and hearing, getting involved with those people on behalf of the Care Quality Commission. And, you know, not one of them has been cynical or dismissive. They really believe in the process, not because they're naive or just sort of nodding heads, because they are passionate about how important the inspection of the services that they mostly really love are. And they can tell me what good looks like and outstanding. And I can give you some ideas. If you go in for outstanding or good in social care and your parent or loved one has got dementia, early or longer stage, the same people turning up is what they call continuity of care in the big terms. It just means you're not faced with strangers and seeing the loved one get upset because they don't know who's knocking at their door. And they don't know why they're having somebody come different. It's there in what people say. And if you're in a hospital, and this is back to my analogy with the water pills, it might sound less sexy than the metrics, but actually the need to go for a pee when you're suddenly in hospital is fundamental to responsive and caring care, but it's also about effectiveness and safety. Because if the corridor's too long, or if the staff tend to get a bit irritated with you, you'll have falls. You'll often, dreadful to say, I've heard people tell me they've stopped having a drink at night. They start dehydrating because they're frightened they might wet the bed. That's what it's about, getting involved. And that's where you get an idea of what good and outstanding and not good enough is. And if you read this, you can keep on with the work that the Care Quality Commission are going to do. Thank you very much.
So I'm not going to even try and follow that. I'm just going to introduce Mike Richards, who's the Professor Sir Mike Richards, our Chief Inspector of Hospitals, and Mike's going to share with you the work he's been doing about engagement. Mike, over to you.
David, thank you. Good morning, everybody. I hardly need to now because actually Nick has just done it for me. You know, that is what an expert by experience can do, and I have seen him doing it on our inspections. So I think the case is already made. I'm responsible for acute hospitals, for mental health services, for community health services and ambulance services. And I do think this is an important day in saying what we are going to do, and you'll hear it from my colleagues as well, and how we all do really see involvement as being important. I think we probably will adopt the term people plan very quickly. And it is vital in each of the areas that I'm responsible for. So I just want to give a few examples. And it's at each step in the process, really. The first is the involvement of experts by experience, or patients and carers, in actually the planning of what we're going to do. So in the mental health area, we have an expert reference group with service users as part of that group, and they are helping us to define what good looks like. That's setting the standards, if you like, and also talking to us about how we might go about our inspections, how we might, when we're on our inspections, seek the views of service users about individual trusts. So already they have contributed on that. And then the second bit, and that's the bit you've already heard about, is by being part of our inspection teams. In the acute hospital programme that we've already got fairly far down the line, we've done 18 inspections so far, we take teams of around 30 people. That involves doctors, nurses, managers, CQC inspectors, and importantly, experts by experience. On each one, we have 4 or 5 experts by experience. And what that enables us to do is to split into smaller teams, so that there's a smaller sub-team going and looking at the A&E department, one going and looking at maternity and paediatrics, one looking at the medical wards, the surgical wards, etc. But each of them will have an expert by experience on that team. And as you've heard, they then talk to people who are actually users of that local service and get their views. And we specifically, obviously, for those teams, we select people who've not had any involvement in that particular trust, but they are then talking to people who have had. And we will do the same for mental health and community services. The third step is asking people who have had that local experience. So we do that in a number of different ways. First of all, we always hold a patient and public listening event. Usually, so far, we've done that early evening towards the beginning of our inspection so that we can hear the views and we can then act on them afterwards. We tend to hear very polarised views. People who come to those listening events, you won't be surprised to hear, they're either very strongly supportive of the trust in question, or they've had a bad experience and they really want to share that with us too. But we also speak to people in the hospital on the days when we're doing the inspection, people in the A&E. A recent A&E I went to, actually finding that the person who had sat for 45 minutes because he hadn't quite worked out which way you had to get through the system, the triage. Now, if we hadn't happened to speak to him, we wouldn't have picked that one up. So that can be enormously valuable. We can also look at the experience of patients who've not had a good experience at the Trust by looking at the complaints, and we're doing a lot of work on this. How can we analyse complaints that have been sent to the Trust in the previous 6 months months or whatever, in order that we can learn from that, we can see where we ought to be going on our inspections. And in addition to that, of course, we can look at much larger numbers, if you like, by looking at the results of the CQC's own inpatient survey, the cancer patient survey, and now the friends and family test. So there are lots of different ways in which we can do it. And one particular area that I think we should mention is our specific duties under the Mental Health Act, where we do want and will always talk to people who are detained against their will. And then the final step is actually talking to the people who are running the trust and say, how are they involving people? Because that is one of their duties as well. So we ask the trust managers, the chief executive and other senior people, how are they seeking feedback from the people who come to their trust? How are they dealing with complaints? Importantly, are they learning from complaints? And can they give us any examples of how they're learning from that? And we also will speak to the governors of Foundation Trust to see how they are seeking views in the local community of the local population. And so just finally to say, why are we doing all this? Because this is a vital step in answering the 5 key questions that we all have in mind about services. Are they safe? Are they effective? Are they caring? Are they responsive to people's needs? And are they well led? Thank you.
Thanks, Mike. If anybody follows football, you'll know that Real Madrid, who are famous for signing star players, they call them the Galacticos. So we've got 3 Galacticos. This is the next one. Sadly, she supports Sunderland. But anyway, Andrea, who's our Chief Inspector of Adult Social Care. Andrea Sutcliffe.
Thank you very much, David. And of course, that gives me the opportunity to say that we won last night and beat Chelsea. Thank you. OK, really pleased to be here. What does a really good service look like for someone living with dementia? How do I know if a service is outstanding for a young person with a learning disability? What's it like to be vulnerable and isolated, relying upon others to live my life? And how would I feel if I was too worried to raise a concern for fear that nobody would take any notice, or worse? I'm a 49-year-old professional woman in good health, living an independent life. Yes, I may be the Chief Inspector of Adult Social Care, but what do I really know about the services we regulate? I've never had that direct personal experience, and I haven't cared for someone in that situation either. But others have, and for me to do my job properly, to truly be on their side, I need to understand their perspective, walk in their shoes, and consider how services look through their eyes. I was asked by Nigel to give a personal story about why I think this is important. And to be honest, I had too many to choose from. I've been affected by so many. The granddaughter who sobbed in the car after every visit to her grandma who was living in a care home, even though she was thankful for the care that was being provided. The mother who had lost her son but wanted her insight to benefit others. Insight she had gained from years of battling with services for young people with learning disabilities. The young man who said how angry he was when an attack left him in a wheelchair for life, and how the support from his peers had been so important. And the daughter who spoke so tenderly about the support that she had received from the care home staff when her mother had passed away. All these and so many more have enriched my understanding of the services we regulate and how people experience what's good and what isn't. And I'd be a fool not to use this wisdom, experience and insight to make sure that what we do is the best it can be. And it's why I've said that we should apply the mum's test to everything we do. Is this service good enough for my mum, or whichever loved one is relevant? And if it is, that's great. But if it's not, we need to do something about it. And I should also say that I learned so much from my time at the Social Care Institute for Excellence and with the Think Local Act Personal Partnership about working in co-production, how important and helpful it is, but actually how much fun it can be too. So since I came to the Care Quality Commission, I've been delighted to build on the principles that we've set out in putting people first. I've been clear that we will work in co-production with people who use services and their carers to design our new approach. And we have the second meeting of our co-production group tomorrow. And we're so lucky that people are prepared to spend their time to develop the questions that we will ask and the way that we will ask them on our inspections. We will also extend and expand the role of experts by experience in the inspections we undertake. As Mike has said, this will really help us to get under the skin of the services we are inspecting by making sure we spend time talking to staff and people who are using those services. And as well as playing an active part when we visit care homes, experts can also help us contacting people in their own homes when we need to. And again, I'm incredibly grateful for their time and expertise. And like Mike, we will listen and take into account the views of people using services. In this, our links with local groups will be particularly valuable. Local Healthwatch will be a key partner, and we are keen to develop our work with them further. So we know that the information from their enter and view visits made by volunteers can be very useful, particularly when our local teams work together with local Healthwatch to coordinate activity wherever possible. There are lots of opportunities for us to involve people at a local level through voluntary and community networks, and we need to be making the best use of them all. So I welcome the organisational commitment that we have made to work with people who use health and social care services, and I would like to add my own personal commitment as Chief Inspector of Adult Social Care. As Nick has said in calling this a people's plan, people are at the heart of everything we do. We need to involve them, think about them, and listen to them. It's the right thing to do. Thank you.
Andrea, thank you very much. And third but not last, or certainly not least, Professor Steve Field, who's our Chief Inspector of General Practice. Steve.
Gosh, how to follow my colleagues. I'm a GP, a practicing GP in Birmingham, as well as being Chief Inspector. And you know, I really believe in our universal NHS. It is, on the whole, for the vast majority of people, the most wonderful institution, organisation, group of people doing things for patients that you could imagine. But unfortunately, it's not as good as it could be, and some people are let down. And I'm here, I've been hired in order to be leading on behalf of patients, the public and future patients in future generations, across general medical practice, dental care, care in prisons and secure environments, to look at child safeguarding and other areas. As a GP, I'm right at the centre of where the health part of the service is, but without social care, we're nothing. It has to become a much more joined up, coordinated, integrated, patient-focused care service, and we're not there yet. If I could concentrate a little bit on general medical practice, because that's going to be where most of our energy is going to be over the next few months, setting up a whole new system. As a GP, I know that it's increasingly difficult to practice, particularly in the cities, because the workload is so high. So GPs across the country will have to change. They'll have to work much more efficiently and effectively with their teams and listen more to patients. I thought it was what we did. We would talk to our patients and be responsive and adapt our services. I thought we'd got to the point where most of us had patient participation groups and learnt from them. Unfortunately, whilst most practices are moving in that direction, a few are not engaging effectively with the patients, the public, and their carers. And I personally don't believe that GP surgery can actually move forward and serve the patients without co-production, working with them to design the services. Mike Richards, who's one of my sort of professional heroes, as well as working with him, we've talked for years about the problems with cancer diagnosis and the fact that our survivals in England perhaps aren't as good as they should be. And that could be that patients are still feeling grateful for this universal system and don't want to trouble clinicians. It might be that they're not aware of the symptoms. It might well be that they can't access the GP or they're referred late. And so what we've got to try and do is try and improve those outcomes for patients. And we can only do that by listening to patients and their families about how they can access the service and how they can take that forward. And I believe we're in a very powerful position to work with patients to make a real difference across England. In general medical practice, we're going to be looking at specific areas of care. So we'll be looking at the practices to ensure that the elderly, who require slightly different services on the whole to the working age people, have responsive, safe, caring, effective and well-led services. And in addition to looking at that group of patients, we'll also look at the large and increasing number of patients with many long-term conditions. We'll look at the specific work that GPs will do with mums and babies and small children, which needs a coordinated response with their colleagues as health visitors and often with children's centres and others. And my passion throughout my career has been about what do we do to improve the care for those groups which some people say are hard to reach. I don't believe any group is hard to reach. If you can be bothered and you put vulnerable people at the centre of everything you do, that's what we should be doing. The moral compass for our NHS is how the NHS serves the most vulnerable in society. And I'm absolutely thrilled that the CQC board has supported our proposals that we'll also be looking at how GP surgeries looks after the most vulnerable in society. Whether that's people who are homeless, whether it's travellers, whether it's people with learning disabilities, we will rate those practices against for those groups, which means that if you've got an excellent practice, we'll celebrate that so that other people can learn and share the good practice. The stories that I hear going around the country about access for those vulnerable groups are very alarming. But also, when you talk to people who aren't in the vulnerable groups, they're having difficulty accessing GPs at the moment as well. And surely access needs to improve, and we will sort of focus on that. In order to make this work, we need to co-produce everything we're doing. And as Andrea rightly said, asking people from all of those groups to come and help us with our planning is essential. On every visit to a GP surgery, we're going to have GP leadership and trained inspectors, but we'll also have what we're calling experts by experience, people who've used the service. But for general medical practice, being at the centre of the NHS, we also want to make sure that it's representative of all of the different groups that general practice serves. I want to see people who've either homeless or experienced of being homeless, actively involved on visits, as well as people, for example, from the transgender community. We need to increase our numbers of inspectors as well as patients from minority groups, BME groups, because general practice serves everybody. And we also, as Mike quite clearly said, need to work on how we get information so that we can make judgments. And that means we need to reach out to those communities, to children who are often forgotten in the design of health services, so that they can be actively involved in everything we do. So that when we come to rate practices and share our reports, it touches the hearts of everyone that we're serving. Because if everyone connects emotionally with what we're doing, I think we can make the care system generally a much better place. So finally, I'd just like to say I promise. I was going to do the Scout law then. I promise to do my best. And I really mean that. So growing up as a Cub Scout and onwards, I really do genuinely promise to do my best for everyone in this country to try and make our health and care service the best it could possibly be. We will succeed on this. We're absolutely determined, but we can only do that with the active participation of patients, carers and future patients who are not yet patients, but the health service is for now and for future generations. Thank you very much.
So for any of you who forgot how to do the wolf howl, Steve will give you lessons afterwards. For the first time this week, I've been on time and in front of myself on anything I've done. So this programme says we should be about 9:15. So we've got 10 minutes that we didn't expect to have. I was laying money Steve would spend longer than 10 minutes, but he hasn't. I think my colleagues, although they haven't been informed of this, will be very happy to answer any difficult questions anybody in the audience has. So that people who are listening to it on YouTube can actually engage with this. Nigel's got a mic, so if you just wait for the mic and ask any questions or raise any points. And if we take 2 or 3 at a time, and then I'll invite Mike, Andrea and Steve to have a go. So David, who follows us and last month went from London to Newcastle overnight to be at one of our board meetings in Newcastle. So I think it's only right that you should have the honour of the first question, David, and we'll come to you afterwards at the back.
Thank you very much. I approve everything that you've said, all of you have said, but I'm just wondering if you have ideas about involving users of services who can't speak for themselves or who are too frightened. And I suppose this is particularly for Andrea, but it affects everybody. Because otherwise you're going to get a bit of a skewed sample and lots of people perhaps saying it's very, very good because they're strong enough to make it good.
Very good question. And let's take 3 and then we'll come back to them all. So there's a gentleman at the back in the striped shirt.
Good morning, thank you. Yes, it's encouraging to hear what's been said this morning, but I go back to the Healthcare Commission and what existed then, which was a concordat arrangement with other regulatory bodies. And I only say that because when we look at things like Winterbourne View and other things, it kind of like makes me wonder where was the dialogue between the organisations. So it's not about pointing fingers, but it's just that, you know, it's understanding who does what, because then the public can surely recognise that if there's a registrant that maybe needs to be called to question, should it be the Nursing Midwifery Council or should it be you guys, you know, in terms of safe, effective care and that, so that we're all clear about that. Thank you.
Okay. Do you want to say who you are? Do you mind?
Somebody that's just come off the street for the free breakfast. My name's Francesco Palmer.
I'm sorry you haven't had your breakfast, but anyway, were you signalling in the middle on the second row? Lady with the blonde hair? No? Yeah? No, you weren't. Okay. Any more? The second gentleman in the striped shirt at the back. Bren.
Thanks. Bren McInerney. I have the privilege to co-chair the Care Quality Commission's Equalities Voices group with Kay Sheldon, and very privileged to do that. I was really keen to hear that we're going to reach out to those voices on experts by experience that we may or may not be doing as well or as well as we need to at the moment, really. And I think a lot of that, in my limited experience of working with some of the groups that we've talked about, is actually trust, really. It's hugely important, and we have to, rightly so, earn that trust as well. So I'd be really keen to hear how we're planning to do that and whatever. I'm not on about planning to gain the trust, but what approaches have we got to actually achieve that, really? And again, you know, when we look at those voices from people who are homeless and whatever, really, again, they may well be quite vocal and not always representative of all homeless people as well, really. So just a couple of caveats in there as well.
Okay, so I think 3 questions really about how are we going to do this. So how are we going to engage with people who might not have a voice or are too frightened to come forward? How are we going to go beyond the fine words in concordats? And then even within generic groups like people that are homeless, every individual is different, and therefore how do we do that? Okay, so Andrea, you were invited to kick off, I think, so...
So I will. Thank you very much. So if I pick up David's question, which is obviously a really important one, and I think that there are at least 2 ways that that we can be doing that. The first is with our experts by experience, because actually the ability of our experts by experience to speak to people and to gain their confidence and trust, as Bren says, kind of doing that is really important, and enable us to find out from people what's actually happening is absolutely critical. And one of our experts by experience explained to me that she was doing a visit in a care home. And the care home was largely for people with dementia, but on the second floor, it was people who had pretty advanced dementia were living. And on the ground floor, lots of activities, lots of interaction and engagement, looked really fantastic. But on the second floor, she spoke with a gentleman for some considerable time, and it wasn't an easy conversation to start off with, but she gained his trust and began to get some insight from him. And what she found out was that all of those wonderful activities on the ground floor were not really being shared with those people with advanced dementia on the second floor, and it was because she'd spent the time and had really got into it that we were able to draw that out and to identify that and feed that back, because obviously quite clearly there are things that can be done, activities that people with advanced dementia can be involved in and shouldn't be neglected. So I think that's just an example of how we can do it. The second approach, I think, is also about thinking about how do we cast our net wider in terms of finding information out from people. So looking at advocate groups, for example, looking at the local community groups who may well be setting up befriending services, going into care homes, supporting people in their homes. And we need to make sure that we're getting information from those people to find out what's going on as well. So those are some of the ways that I think that we can try and help. Thank you.
No cameras?
As you know, and so for those of you who didn't pick that up because David didn't have the microphone, he said no cameras. As you know, David, cameras was something that we suggested in a fresh start for the inspection and regulation of adult social care, was something that we needed to look at because it has indeed been raised by people as a way to find out what's going on in some services, and we have a whole range of opinions about it. We should be doing it all the time. We should never touch it with a barge pole. So we're having a conversation with folk about that, and we'll be developing that further in the new year.
Steve.
Thanks. I welcome the question about vulnerable groups. 2 other things I do outside here to keep me busy in my spare time is I chair the National Inclusion Health Board, which is the board working to government on supporting people who are prostitutes, homeless people, travellers and vulnerable migrants, and so I'm linked into all of the networks there at a national level, and I also volunteer at a Sikh Gradwell, a temple, where I provide a little bit of help on them setting up some health and care services. And so I'm connected not just personally with my patients, but also in different ways, because in everything I do and want to do, I think if you're connected to those groups just by holding your meetings in hostels, by going out and not spending money on hotels for meetings around the country, but going out into the community where part of the meeting you're meeting with local people, not bringing them in as tokens, but actually actively involve them. And so I think one of the things that it's a really sad couple of weeks with Nelson Mandela dying, and if you look back at some of the real reformers and social leaders, Gandhi, Mandela and others, they all had one characteristic, which was to live out the values and try to demonstrate as leaders what those values are. And David I think, has done a wonderful job really turning around the Care Quality Commission, which is why many of us have joined. You have to live out those values. And what I think I have to do is demonstrate to a few hundred people we're about to recruit across primary care that we're living those values. And in demonstrating what we're doing as national leaders, we want that to be replicated locally. I don't think the CQC should get into the tokenism of meeting with groups to tick boxes. This has to be living out values, connecting emotionally with people and listening. And that means if our primary care groups are meeting in a hostel, we should be listening to what their stories are. Because the narrative of people's lives, as Andrea demonstrated earlier on, is so important. And that's what we'll do. But also we need to recruit. We need to hire many of you out there. If there are people watching on the internet and you in the room, we need more people to be involved in helping shape what we do. And my promise is that we will be inclusive. We'll succeed only with the help of people in this room and around the country.
Michael.
Thank you. First, in response to David, I think there is a risk that we will get a skewed picture. I think we have to be aware of that risk, and we constantly have to think of how we overcome that. But I think one of the ways is by recognising that we're not just talking to patients, we're also talking to carers. And when we're talking about experts by experience, we deliberately mean both patients and carers. So I think that voice does come through strongly and has already come through strongly in our inspections. In response to Bren, in terms of how we reach out to specific groups, I should have mentioned in my comments earlier that as part of our inspection programme, we do attempt to reach out to specific groups in advance of our inspections. And indeed, in one of our inspections, we very specifically reached out to an Orthodox Jewish community. And what we heard from them was they liked the hospital so much that even on a Friday, when they couldn't take public transport, they would walk the extra distance to go to that hospital. I think that was quite a telling comment. It was a very positive one in that case. And then finally, in response to the whole business of how we're working with other regulators, what I can say is we are doing that. We already have various memorandums of understanding, but in addition to that, we've got detailed work going on. Just earlier this week, I was meeting with the Chief Executive of the General Medical Council. We already use their survey of doctors in training, which does help us to know which parts of a hospital may be the ones we need to look at more carefully and which not, because it gets a very high response rate, and the surgeons in training versus the physicians in training, we can tell the differences there. And so that can give us alerts. But we were talking about what more we could do, and perhaps the number of referrals that have been made to the GMC can act as a smoke alarm, again, to add to all the other smoke alarms and build us a picture of what's going on in a trust. So I think we are trying to cover that area as well as the others.
Okay, colleagues, thanks very much. I think we probably now should be moving on. I know that some of you are going to go into a meeting with Nigel and the team and have some further discussion about how we move that forward. We're going to move now into a board meeting. That's a public meeting, and those of you that have had enough of Nigel for this year are more than happy to stay with us and listen to the board meeting. I want to say thank you very much for what you've done, what you've contributed. Our job, our purpose is to make sure that people have services which are safe, effective, compassionate and high quality, and we do that so that those services can improve. And if we're to do that effectively, we need the help of people that use services, as my three illustrious colleagues have said about how that we do that. We cannot do this on our own, and we need your help to do that effectively. I do personally believe that people are experts in the care that they need to receive, and particularly those people with long-term conditions. You know yourselves better than any professional and you need to be involved in that. David Pryor and myself have talked often over the past few months about what are some of the key ingredients for success, our success in CQC, but also success in services. And David hosted a dinner last night, and Michael West, who's a professor from Lancaster University, talked at the dinner, and he echoed something that David and myself have been talking about, which is the importance of humility in those of us that work in services, whether we're delivering services or whether we're involved here at CQC in inspecting those services to ensure that services are the best they can be. And it's worth, probably in connection of the conversation we've had this morning, just emphasising the importance of humility, the fact that we don't always know the best, and therefore if we are going to truly reach for improvement and reach for excellence, then humility is a key ingredient of any successful individual. I'd also add to that empathy, the ability to see services through the eyes of others and not just through the eyes of yourself. I believe that's a facet of emotional intelligence as well, and I think they are key ingredients. The ability to take criticism, listen to that criticism and process it as free intelligence and not see that as a challenge on your integrity or very reason for existing is a big ask for many of us. Most of us like to be told we're doing well. Very few of us like to be told we're not doing as well as we could be. And therefore, how we conduct ourselves and how we open ourselves up to be more empathetic and more humble in the way that we do our jobs, I think is a key ingredient for how we can be the best we can be. So, we frequently say we're on the side of people who use services. I have to say that's the most difficult sentence I utter on a daily basis. Because if you follow that logic through, it takes you into some pretty uncomfortable places, I have to say. But that's the journey we're on to come to the Mandela point. I'm not sure we'll ever get to that destination, if I'm being brutally honest, but I think if we don't have that ambition, then we'll never succeed in where we need to be. So we'll work hard as a Commission. I know I speak for the board as well as my colleagues, but I also know with some confidence I speak for everybody that works in CQC, because my belief is that everybody has come into this organisation because they want to make a contribution to making a difference. And we are deeply committed to working with people who use services so that that can help us in our purpose, and through that we can help people get access to the services which will allow them to live the lives that they would choose to live. So thanks very much. I don't know whether you are going to get breakfast, so if you've come for your breakfast, I'm really sorry. Somebody's saying you are going to get breakfast, so breakfast is served in another room. If you'd like to stay, they'll turn this room round a little bit so it's fit for the meeting we're going to have. But on behalf of the board and my three colleagues here, thanks very much for the work that you've done. Thanks to Nigel and his team. I think they're all here for the work that they've done to actually set this out in writing. The document's important, but the document by itself isn't sufficient. This is about what we do, so please judge us on what we do and not on what we say. And thank you to our colleague who's avoided drawing me, for which I'm eternally grateful, but has got Andrea and Steve Fielding, because they're easy. So, so thank you to our colleague. It's worth looking at, and we'll see you about the place in conversation. So thanks very much indeed for this morning. Thank you.